Good morning, all. Today we'll be discussing about the post-operative management and evaluation of complications after anorectoplasty in ARM. The objectives of this seminar is about the perioperative management, the follow-up protocols, including the anal dilatations and avoiding constipation, and the complications, including the evaluation and management of the same. Coming to the post-operative management, in patients who are operated without a covering colostomy, usually we tend to go for an posterior sagittal repair without opening the abdomen. These patients are usually fed on the same day of the surgery. The pain is minimal and patients feel comfortable in the presence of their parents. The hospitalization is usually for a duration of 48 hours for IV antibiotics. The patients are then discharged and followed up after 2 weeks in OPD to start the process of anal dilatations. In patients with colostomy and who also undergo simultaneous laparotomy, oral feeds are started usually 2 to 4 days after the surgery, depending on the degree of IBS related to the manipulation of bowel. In patients who have previously undergone multiple surgeries, the definitive surgery duration is longer and there may be a prolonged IBS. In longer surgeries, the child also might need ICU monitoring post-operatively. However, we also go ahead with the ERAS protocol implementation for colorectal surgery even in pediatric populations, including intraoperatively a laparoscopic technique which can be helpful along with adequate anesthesia. Post-operatively, early mobilization and early oral intake with clear fluids are also started, which again results in reducing the length of stay and overall morbidity for the patient. Coming to patients on loop colostomy, these loop colostomies can sometimes be totally diverting and the entire stool goes into the stoma bag. But when loop colostomies retract, the stool passes into the distal wall. This can be prevented by putting a Foley's catheter in the distal colonic limb with the balloon inflated or placing a purse string suture in the distal stoma, which is absorbable, and thus this can prevent the spillage of stool into the distal limb. In patients who are operated without colostomy, preoperative bowel preparation to clean the entire GIT is indicated. During surgery, a PICC line or a central venous catheter is put for the patient to receive parenteral nutrition. The child is kept in NPO for a period of 7 to 10 days, which is ideally explained to the parents preoperatively. After 7 days, an assessment of wound at the perineum is made, and if the wound is healthy, the child is allowed only. If there is a dehiscence, resuturing can be done, and the NPO period is increased for 2 to 3 days. If there is a complete dehiscence, another colostomy is done, and the child is reoperated after 3 months. Further studies have shown that in single stage repair of isolated low ARMs like vestibular fistula or perineal fistula, early initiation of post-operative feeding is safe. It results in a short length of stay and is not related to increased wound complications. Coming to local care, there is no need to restrain the movements of the child. Double diaper is encouraged as it serves as a cushion. A posterior approach is basically painless. However, the patient is advised to avoid jumping or sitting roughly. An antibiotic ointment is usually applied over the wound and genitalia in female patients. Urethral catheter in females can be removed early and is not associated with wound dehiscence. In males with rectourinary fistulas, a Foley's catheter is left for a period of 1 week, and following removal, urinary retention is unusual. In patients with poor sacrum, tethod cord, or a very high malformation, the child can go into retention after removing of catheter. In cases of neurogenic bladder, previously diagnosed, an SPC can be left behind, and the urological evaluation post-operatively can be done using a UDS. In patients who have a cloaca, the catheter is carried for 2 weeks who have undergone a total urogenital mobilization. In patients with a short common channel. In patients who have a common channel longer than 3 centimeter, an SPC is indicated because these patients can usually go ahead with urinating normally after 3 months. In patients who have severe kidney damage, hydronephrosis, megaureters, or complex malformations, it usually takes them longer than 3 months to pass urine normally, and a vesicostomy is indicated in them. Coming to the protocols for anal dilatations, these are usually started 14 days post-operatively when the patient is followed up in OPD. On 14 days, the initial size of the dilator is determined and the parents are demonstrated how to pass the dilator. Initially, dilation is done twice a day, and once the dilator is passed, it is left behind for 30 seconds. These dilations are usually advised to be performed before meals. The baby must be restrained properly, keeping the knees against the chest. The size is gradually increased every week till the desired size is achieved according to the parent's age. This desired size of the dilator is in millimeters of the diameter of the dilator, and accordingly is used. For 0 to 4 months, the size is 12. 4 to 8 months is 13. 8 to 12 months, 14. 1 to 3 years, 15. 3 to 12 years is 16, and more than 12 years, 17 number. The frequency of anal dilatation, once it has reached the final size, the dilatation twice a day is indicated until the dilator passes easily. Once we have achieved that, the frequency should be tapered to once a day for 1 month, every other day again further for 1 month, every third day then for 1 month, 2 times a week, then once a week for 1 month, and once a month for 3 months. And then it can eventually be stopped. The anal dilatations are a source of potential psychological trauma because of the pain that is provoked. In patients who have a good sphincter mechanism and rectum remains within the limit of sphincter, anal dilatation is ideal. To keep the anus of the patient, the anus of the patient should heal with the rectum open. That is why the anal dilatation is important. Should not be started in less than 2 weeks after surgery because it can damage the sutures. If we start the dilatation after 2 weeks, there will already be fibrosis and the dilatation will be difficult. This is a picture of a post-operative appearance of a correct anoplasty that has been done with the patient having a good sphincter mechanism. The anus is closed and anal dilatation is definitely indicated. Another protocol that is followed was dilatation under anesthesia weekly, but it is not usually recommended because the overdilatation, we tend to do overdilatation, which produces even further fibrosis. The importance of anal dilatation is if it is not followed, it provokes anal stenosis. Next, what is important in the follow-up for these patients is to avoid constipation. It is the most common sequelae when the rectum of the patient is preserved. Resection of if the initial surgery is with the resection of the rectum and the colon has been pulled through, the child would not have constipation but may have fecal incontinence. There is an associated hypomodulated disorder of the rectosigmoid with ARM patients, which eventually translate into constipation after definitive surgery. More severe, this constipation is more severe in patients with lower defect, and a more proactive management is indicated in them. This constipation can lead to fecal incontinence, which can present as fecal incontinence, but is actually an overflow pseudo incontinence. In patients who have a good prognosis malformation and a good repair has been done, but they have not received sufficient care for constipation, there can be a severe fecal impaction with megarectum, and this can further lead to fecal overflow pseudo incontinence. This may from the time of colostomy closure until the age of bowel control, which is 2 to 3 years, we have to focus on avoiding the constipation and to achieve the regularity of bowel movements. The parents also need to ensure that the child passes stool every day and is actually really emptying the colon. As a protocol, abdominal X-ray films can be used at 1 week and 2 weeks after closure, and then at 1, 3, and 6 months. Further, to avoid this constipation, once the child is more than 1 year, a regimen of 3 meals per day with no intervening snacks can be used, which eventually helps to produce a gastrocolic reflex. In patients who have episodes of diarrhea followed by episodes of constipation, the toilet training is difficult. This can be managed by a small breast enema according to the bowel habits of the child. Laxatives of senna derivative or lactulose can be used. This amount of laxatives that is required has to be decided by the trial and error with each patient. Once laxatives are started, they're usually required on a permanent basis. Toilet training to the patients of ARM who have a good prognosis ARM, training can be done by age of 2. Mostly they're free of constipation or just with or without laxatives. They achieve a proper bowel control with 2 or 3 bowel movements a day at regular intervals. In patients who have a poor functional ARM, bowel management program is to be initiated by the age of 3. In patients who have a functional prognosis of 50 to 60%, bowel management should initially be started, and then a laxative-free trial can be given with a regime of 3 meals per day with laxatives and fiber. If on this trial there is no gain of bowel control, the patient is again taken up for bowel management with enemas for 6 months or a period of 1 year, and then the patient can be reassessed next year or after 6 months if the trial can be given again and the child can achieve bowel control. Coming to urinary control, it is based again on the original anatomy and the defects of sacrum and tethered cord. In a child who is 1 year old and passes urine in episodes, that is every 3 to 4 hours, is a good stream and remains completely dry in the intervening period, good function prognosis, it is a good function prognosis and UDS is not indicated. After surgery in a 1-year-old child who has a complaint of dribbling, urinary problems are anticipated. If the child has a large atonic bladder, intermittent catheterization can be useful, but patients with hypertonic bladder and a poor neck bladder neck are more difficult to manage. CIC is essential for the protection of upper urinary tract, especially in cases of neurogenic bladder and reflux. Coming to the complications after the surgery, it is essentially divided into 3 groups. Group A of fecal incontinence, which requires surgery. Group B of perioperative complications, and Group C, which is because of the mismanagement of constipation. In fecal incontinence requiring surgery, this is another complication which is commonly seen in patients who have fecal incontinence, that is perianal dermatitis, and is very distressing to the parents as well as the child. Patients who require surgery for fecal incontinence are those who have a malformation associated with good prognosis, rectum that is mislocated, they have an intact rectosigmoid, a normal sacrum, and an intact sphincter mechanism. However, now these surgeries for fecal incontinence is reducing after the posterior sagittal approach has been adopted. The anorectal incontinence continence can be divided into 3 groups. A child that has achieved a total continence, which has no swelling, no constipation with voluntary bowel movements, a partial continence, and a complete incontinence. Partial can again be of type A, B, C. A, that can be managed with diet changes and laxatives. B, which the child when has constipation with overflow swelling but remains clean with enemas. Type C, which has partial insufficient muscle complex, has occasional swelling with no constipation. Incontinence and when child is incontinence, it can again be divided into type D and E. Type D is with complete insufficient muscle complex and the child has encopresis. And type E is because of the motility problems and constipation is not manageable. The management for this will be further discussed. Coming to the perioperative complication, the wound infection is usually uncommon and is more prevalent with loop colostomy which are not completely diverting or in cases which are operated without a colostomy. It usually affects only the skin and subcutaneous tissue. They heal secondly without a functional sequelae. This particular image is of a wound essence after ASAR, the complete wound essence. Anal stricture is the most common surgical indication for a redo surgery in operated cases of ARM. This is usually because of an inadequate blood supply, tension at the anastomosis, or the damage to the intramural blood supply of rectum during dissection, and also when the parents do not follow the prescribed protocol for anal dilatation. The rectal problems could be dehiscence or infection, retraction of the rectum, acquired atresia of the rectum, again because of excessive tension or inadequate blood supply, or rectal prolapse, which is more commonly seen in lap-assisted surgeries. Rectourinary or rectovaginal fistula can be seen. These fistula could be a persistent fistula, a rectorectal fistula which was not dealt with in the definitive surgery, a recurrent fistula which opened, an acquired rectorectal fistula which was inadvertently created during the repair, or acquired rectovaginal fistula which occurs because of a failed attempt at repair of rectovestibular fistula. A persistent urogenital sinus can be seen after surgery in patients who are born with a cloaca. The child undergoes a repair for the rectal component, but the urogenital sinus was ignored. This is a descriptive image of the same, where the urogenital sinus has not been dealt with. The common opening is still present, but the rectal component was dead. There could be an acquired urethral atresia because of the devascularization of pulled through or reconstructed new urethra, or in males when urethra was accidentally transected. There could be acquired vaginal atresia because of the complete fibrosis of vagina, excessive dissection to mobilize a high vagina, or in an attempt to repair a cloaca. Posterior urethral diverticulum is when a retained portion of the rectum is left attached to the posterior urethra. It is usually seen in rectobulbar fistula, which are repaired by a transabdominal or laparoscopic approach. The patients usually are initially asymptomatic, but later on develop symptoms of passage of mucus via urethra, dribbling, orchidoic epidermitis, UTIs, or urinary pseudo-incontinence. This image initially shows this PUD, that is pseudo-diverticulum that is created, and this can be repaired after by the excision of the diverticulum. Other urological injuries can be because of the transection of the bladder neck, transection of the urethra, injury to the vas deferens, seminal vesicles, prostate, or injury to the ectopic ureters. However, this can be avoided by a posterior sagittal approach after performing a good distal cologram. Neurogenic bladder is another complication that is seen in operated cases of ARM. In male ARM, it is extremely usual. It is usually seen with very abnormal sacrum or with spinal anomalies or when denervation of the bladder or bladder neck is done during repair. In cloacal malformations is seen when there is deficient emptying mechanism of the bladder. Typical Christmas tree appearance is not seen and the child has a flaccid, smooth, large bladder. Intermittent catheterization is usually helpful in these patients. Femoral nerve palsy is a transient palsy usually seen in adolescent patients when operated. This is a consequence of excessive pressure on the groin and can be avoided by adequate cushioning of the patient's groin area during surgery. Specific to laparoscopic approach, the most common indication for a laparoscopic approach is the rectoprostatic and rectobladder neck fistula. They can be inadvertent injuries to the bladder neck, urethra, or an ectopic ureter. There is a risk of leaving behind the distal cuff, forming a posterior urethral diverticulum, especially in cases of malformations below the peritoneal reflection, and this may necessitate a secondary surgery. Rectal prolapse is also more common in lap-assisted surgery, and a pelvic hitch can be employed to avoid this complication. Rectal prolapse following PSARP is an incidence of 3%, but after LARP is around 11%. It is also seen that higher malformations of poor sacral and poor developed sacrum or pelvic musculature. A significant prolapse can also lead to ulceration, bleeding, or mucus production. It can interfere with anal canal sensation and also lead to poor functional prognosis. This repair for prolapse should be ideally done before colostomy closure, but in some patients with constipation, this prolapse is seen after colostomy closure. Coming to the group C of complication, that is the sequelae of constipation. It is the most common functional disorder. In this X-ray, we can see a colon that is loaded, the ascending as well as the descending colon is completely loaded. This incidence of constipation is inversely related to the frequency of voluntary bowel movements. The best prognosis for bowel control in patients who have the best prognosis for bowel control, they have the highest constipation, and with poor prognosis, they have a low incidence of constipation. Again, it is related to the degree of preoperative rectal ectasia. Colostomy is not allowing irrigation of distal colon, which lead to the formation of megarectum. Transverse colostomy, which lead to micro left colon and dilation of the rectosigmoid. Loop colostomies, which allow for the passage of stool, which are not diverting, and distal fecal impaction. To achieve a better ultimate bowel function, the distal rectosigmoid should be kept empty and should not be distended. And also, after definitive surgery, the stomach closure should be planned early. In patients who are referred with especially fecal incontinence, it could be a case of untreated severe constipation or chronic impaction leading to an overflow pseudo-incontinence. This is usually seen in a patient with good functional prognosis and has had a technically correct surgery. But the post-operatively constipation was not adequately treated. The child developed megasigmoid and chronic fecal impaction. These patients should undergo a laxative test to determine whether they were fecally continent or not. Their treatment of constipation with or without a sigmoid resection and laxatives can help us know whether the fecal continence can be achieved. The short-term post-operative complications show an incidence of most commonly with anal stricture of around 38%. Once we can say that the correct repair has been done. For low ARMs, a total continence rate are better, but with higher ARMs, a pseudo-incontinence is seen as more constipation is seen. These complications can simply be described as early and late complications following surgery, the management of which will be described.
Moving on to how to assess for post-operative complications in a patient who is not operated for ARM. There's no standardized protocol for the same, and primarily various scoring systems have been described. The initial three major or more important scoring systems which are predominantly used are the Kelly scoring system and the Penna scoring system. In Kelly scoring system, they focus on three things, that is whether the patient is having staining or smearing, whether the patient is having episodes of soiling or accidental defecation into the diaper, and the strength of the puborectalis muscle. Based on this, we attribute them as cases with good or fair or a poor prognosis. Similarly, according to Dr. Penna, they have classified, they've included urinary incontinence in the mix, and they've included whether the patient is having voluntary bowel movements. That would be the feeling of the urge, whether the child is able to verbalize the same, and if the child is able to hold those bowel movements before the child reaches the washroom. Also, they've included similar to the Kelly scoring system, that is the child is having episodes of soiling, which are occasional or everyday, or which is a constant social problem for the child. And similarly, whether the child is having problems related to constipation that can be managed by dietary changes, or the child requires laxatives or enemas are required, and they've classified it as grade 1, grade 2, and grade 3. Similarly, urinary continence has been taken into account, that is whether the child is having complete incontinence versus certain episodes of mild dribbling or intermittent episodes of wetness in the day or during the night. The third important scoring system is the cricket mix scoring system described in 2005. It's similar to the PENA scoring system. Again, they have taken into consideration voluntary bowel movements, soiling, and constipation. And however, they've not taken into account urinary incontinence in this system. Though there's not a standardized protocol for post-operative in order to ascertain the outcome of ARM in patients, certain diagnostic or investigations have been included into the mix. One of them is anorectal manometry. They correlate well with the presence of continence after the surgery in patients of ARM. Usually, patients should have an adequate anorectal pressure difference, and they should have a normal anal pressure at rest. If these two can be seen in the anorectal manometry, we can think that the child will have a good prognosis. However, in most patients with ARF, a reduced normal anal pressure is noted. Similarly, EMG has also been used. None of these have been standardized, and they are just still under, still not widely used. Again, in EMG, it's recorded by placing 2 electrodes at the anal orifice, and the patient is examined awake without any sedation and in a supine position. We record the external anal sphincter electrogram initially, and we see when the rectum is transiently distended by the balloon, there should be contraction of the external sphincter. This is the inflation reflex. If this reflex is present, that means the child is having a good outcome. In patients with low anomalies, usually this reflex is preserved. And we can see that the electrical activity is seen during rectal filling. That is, when there is rectal distension, there is fall in the pressure, there is increase in the external sphincter, there is contraction of the external sphincter, basically. Patients with intermediate or high anomalies will not show this inflation reflex, and the electrical activity is usually stationary in spite of increase in the rectal filling. Again, anal USG or anal endosonography can be used to determine the sphincter morphology, that is both the internal anal sphincter and the external anal sphincter. In this case, we see that there is a well-defined uniform hypoechoic band, which is representative of the internal anal sphincter, and the hyperechoic band, which is suggestive of the external anal sphincter. Usually, in patients, such as in this case, you can see that there is a retracted internal anal sphincter. Patients with high anomalies will have less adequate distribution of the external anal sphincter compared to those with intermediate or lower anomalies. Usually, it is seen that patients with higher anomalies will tend to have a rudimentary external anal sphincter. And similarly, also the internal anal sphincter is supposed to be congenitally absent in patients with high or intermediate anomalies. However, it's not that every patient with high or intermediate anomaly will not have a well-developed internal anal sphincter. If it is present in these patients, the preservation of the sphincter can help in improving the post-operative anorectal function. Therefore, in post-operative period, if we can assess the same by USG, it will help us determine whether the patient is having good or bad prognosis. As she's already dealt with constipation, the other major problem which we face with patients following the surgery is fecal incontinence. So whenever a patient post-ARM surgery comes to us with fecal incontinence, what would be the various investigations that we can do? One would be to definitely do an X-ray of the sacrum lumbar spine and to rule out various spinal anomalies and the developmental anomalies in the sacrum. The other would be to do a USG, KUB and VCUG if the patient is having some anomaly in the ultrasound, or if the patient is symptomatic or is having some urinary complaints. Another would be to do a contrast enema to assess the colonic motility. And in some centers, MRI of pelvis and spine is also recommended. So now the question would be, why to do all these investigations in these patients who've already undergone the surgery? So the basic idea is to differentiate whether the patient is a case of a good prognosis or a bad prognosis. If the patient is coming to us from outside and we don't know about the exact surgery, then we need to do all these investigations to ascertain whether the patient is having any spinal anomalies or any sacrum agenesis, in order to understand whether these patients will have a good prognosis or bad prognosis. Good prognosis types of defects are usually patients who have good prognosis type of defect patients with a technically correctly done operation can have overflow pseudo-incontinence, and these patients just require laxatives and they can go back to achieving continence. And also these investigations will help us ascertain whether this bowel management is required on a permanent basis or a temporary basis, so we can do patient counting adequately. Similarly, to assess the type of colonic motility and to differentiate whether this patient has a hypermotile colon or a slowly functioning colon, we have to do a contrast enema to do the same. Similarly, to ascertain whether any associated anomalies are there, other investigations are identified. In patients who have a good sacrum and who have a prominent midline groove and who have lower ARMs, these patients are considered to be having a good prognosis for bowel control. There's various techniques, though we do not practice MRI routinely at our center, but certain techniques like this Prsented technique has been described, in which in post-operative patients, they try to ascertain whether the rectum or it's within the sphincter complex or not. In order, they have to evaluate the relationship between the same. So if in this technique, they insert the Foley's into the rectum, the anal canal, and they mark the same using IV lines because they can't use a radiopaque marker in MRI. And they try to identify whether there is symmetry of the sphincter around the anus and how is the development of the sphincter muscle and is there any other associated pelvic anomaly. Apart from this, this is a bowel management protocol described by Dr. Bishop and Dr. Penna's team, in which they have said that if the patient comes to us and is already on enema and is not being relieved in terms of soiling or incontinence, they have described the protocol in which they do an abdominal X-ray daily, and they ask the parents regarding what were the results of the enemas which they have been giving, how is the patient tolerating the enema, was it too uncomfortable and the child was having symptoms like vomiting or vagal reflex symptoms, amount of the stool which is coming post the enema application, and what happened after enema application. That is, for after enema application, was the patient clean for the next 24 hours or not? And how much time does it take to implement the management? That is from the initiation of enema application till the patient evacuates his or her colon. So if the patient, despite having been given enema, is still not clean, then there could be two possible causes for the same. That is, one, that the enema was not effective enough to clean the colon per se, or two, that though the enema had cleaned the colon, but the colon is moving too fast, and now the new formed stools reach within the rectum within 24 hours. So how will we differentiate between these two sets of patients when they come to us? The answer is through abdominal X-ray films, according to them, in which in this film we can see that it's a heavily loaded colon, and in this we can see that the colon is hypermotile. So they've divided patients into two groups. That is, group A would be patients who are incontinent, but they suffer from mega rectosigmoid. Basically, their problem is constipation and hypermotility of the colon. And the second group of patients would be who are actually incontinent. They have a non-dilated spastic or a short colon, and these patients tend to suffer from diarrhea. That is the hypermotility of the colon in these patients. So how would we manage these patients now? In group A patients in which hypermotility of colon has been identified, in these patients, we will try to find the appropriate enema for this patient. This enema has to be large and concentrated enough so as to evacuate the colon appropriately. So that the aim is to make sure that the patient stays clean for the next 24 hours or even more if possible. No special diet or medication is necessary for these patients. And if we can just evacuate the colon appropriately, these patients will be relieved. Versus the patients, also it's important to ensure that the enema application is being done correctly. Correct position of the enema is required, and also it has to be ensured that when the parents are giving the enema, it's not either leaking out, the enema tube is not leaking, or the enema is not being given anti-gravity, because then the whole content will come out. The second group is the group which suffers from hypermotility of the colon. These colons are very easy to clean with a small amount of enema. They don't need a large volume, they just need a small volume, which might not even be concentrated enough. The aim is to keep the colon quiet. In this set of groups, giving loperamide or pectin or giving a constipating diet might have some role. We have to advise them that certain food products like bananas or potatoes, all this has to be included into that to increase to decrease the colonic motility. In this study by Dr. Penna, they had seen that out of the 348 patients who had come to them for fecal incontinence management after being after undergoing surgery for ARM, they had seen that out of these, they divided these patients into three groups. Group one was patients who were considered as candidates for reoperation because of some technical issues during the surgery. The main focus was on group 2 and group 3 patients. Group 2 were patients who had no potential for bowel control, and therefore these were the actual candidates for bowel management. Again, in these, they have subdivided into patients who had incontinence because of constipation, that is overflow incontinence, and the other who had incontinence with the tendency for diarrhea. And they have included, again, they have found the same results that patients who had poor sacrum, poor sphincters tend to have a poor functional response. And they were able to achieve around 88% to around 97% of improvement in the symptoms of these patients by ensuring a proper bowel management protocol for these patients. This is their rough system for which, according to which they work. The first thing is to do the history, the physical examination, and do the workup, which I discussed, that is the MRI, the sacral X-ray films, the contrast cinema, etc. Now, based on this, the patients are divided into three major categories. The first would be patients who are candidates for the re-exploration or re-surgery. These would be patients who have bowel control potential. They have good sphincters, they have a good sacrum, and they had a good prognostic ARM type of defect. However, the surgery was not done properly, and they have a mislocated rectum also. So in these patients, or there might be other things like there's some stricture or anything else. So these patients are the ideal candidates who need to undergo a secondary pull-through and some additional medical management if required. The second group of patients would be patients who can be dealt with bowel management. These patients had a poor sphincter mechanism, they had poor sacrum, they had poor bowel control, and then we start these patients on this bowel management protocol for constipation or diarrhea. If these patients improve post this, then as the child grows, and we can consider them as candidates for continent appendectomy or the MACE procedure. And in patients in which this was unsuccessful, these patients might require a permanent colostomy. The third group is of the patients who are actually pseudo-incontinent. These patients, like the first group, had a good sacrum, had a good ARM defect. They have a preserved rectum. The rectum is in the correct location as well. However, these patients are primarily just constipated, and they have a mega rectosigmoid. So these patients need to be started on laxatives. And if we can achieve continence with this, we might have to consider sigmoid resection in these patients if the patients do not improve with the bowel management also. Coming to continent appendectomy or the MACE procedure, this procedure is usually considered in patients who have responded to the enema program or the bowel management program. We are not supposed to do this for patients who do not respond to the same. The idea is to create an orifice through the umbilicus through which the child can insert the IFT or a tube and just clean the bowel. In this procedure, we identify the appendix and we bring the appendix out through the umbilicus, and I'll discuss the surgical steps, in which we are supposed to create a midline incision, bring the mobile cecum and the appendix out. We have to create these windows between the appendiceal vessels, and we have to plicate the cecum around the appendix, as you can see in this image. This is the traditionally described approach. Certain approaches now say that this is not required because the appendix will always automatically have its valve mechanism, so we don't have to do the plication. But in the traditionally described approach, they have said that we create the window between the vessels and then we plicate the cecum around the appendix, like somewhat similar to the fundoplication procedure which we do. And the cecum is sutured to the anterior abdominal wall. Now, this cecum will be attached to the anterior abdominal wall, and the distal end of the appendix, which is supposed to be brought out, is then spatulated and then anastomosed to the skin incision. This is the triangular skin incision, and the appendix is spatulated and brought out so as to form a narrow orifice. This surgery is good because it's a very small orifice, and the patient is independent to do the evacuation of the bowel, and it is cosmetically also good for the patient. In patients in which we cannot have a appendix is not available, or appendectomy has been done, then we might consider doing a neoappendicostomy. In this, we can create the same tube, which instead of that, with using a colonic flap. The important thing to remember, the procedure is similar to the continent appendicostomy. The only thing to remember is that this thing should not be done medially, because then the IC wall will be compressed. So it has to be done laterally. That's the only thing. Apart from that, the surgical steps are identical to doing an appendicostomy. Coming to the second group of patients who actually had the only reason that they're not continent is because of incorrect surgery or the incorrect approach or the mislocated rectum per se. In these patients, the problem might be that the muscle complex or the levator muscle is not completely closed around the distal rectum. Or it could be that parts of the muscle complex are actually anterior to the rectum. The third thing could be there is too much mesenteric fat, and therefore the sphincters cannot function around the rectum well. So Or it could be that as you can see in this image, that the rectum is placed too anteriorly. There is anterior mislocation of the rectum. Or it could be that the rectum has been brought out too posteriorly, that it's not in the midline between the sphincter complex. For these, Stephens has described a secondary pull-through procedure. As we can see in this, the rectum has been brought out laterally to the sphincter complex. So in this, again, we do the same perineal PSAP approach, and we try to bring the rectum to the correct position. The idea is to bring the rectum just behind the urethra, and it has to be in the midline, and it has to be between the levator ani and the pubic talus ani. Similarly, it could also be that though it is in the midline, but it is too anteriorly or posteriorly located, so that the sphincter is not well circumscribed around the levator muscle complex, is not well circumscribed around the pull-through rectum. So in those cases also, again, a similar secondary pull-through approach has to be done. Now, for the third group of patients in which who are pseudo-incontinent, who basically are constipated and have a megarectosigmoid. In these patients, if we can offer the parents that either to keep the child on laxatives for a long time or maybe for life, and that will help make sure that the child is clean. Or we can advise the resection of this megarectosigmoid with the preservation of the rectum. In these cases also, the same will help in achieving continence for these patients. Another important complication which we commonly encounter on our day-to-day practice is anal stenosis. Usually, anal stenosis can be managed conservatively with the use of stool tougheners, and we can also advise mechanical anal dilatations, which we routinely do in our protocol. And sometimes even sphincterotomy might be adequate for a patient with mild degree of narrowing. However, for more severe anal stenosis, a formal anoplasty is usually required. However, the best treatment for post-surgical anal stenosis is the prevention of the stenosis itself. So we have to treat the tissues delicately, intraoperatively, use absorbable sutures, and try to do minimal resection of the tissues so that there's no stenosis per se. A variety of anoplasties have been described in literature. The most commonly ones which we practice usually are VY advancement flap, cutback anoplasties in low ARMs initially, which we do, or other anoplasties which have been described include diamond flap, house flap, U-shaped, and C-shaped anoplasties. Usually, the VY anoplasties, which we commonly have seen, are for mild to severe strictures. And these diamond-shaped and house flap shaped, these are reserved for more longer or a moderate type of stricture, leading to anal stenosis. In this, we can see this is the traditionally described the YV anoplasty, advancement anoplasties. These are all flap advancement anoplasties in which we make these incisions and bring the skin outside into the anal canal, and also to relieve the stricture. Similarly, house shape or a diamond shape anoplasty can be done. For longer incisions, a flap rotation anoplasty has also been described. There's one more anoplasty which was first described in 1967. This was the initially created anoplasty. The aim was to create a skin-lined anus. This would help in decreasing the mucus secretion. It would preserve the anal sensation, and it would be cosmetically satisfactory. This is the anal opening, and two triangular. The initially described approach by Nixon had two triangular incisions. It was, however, modified to these kite-shaped areas. These incisions are made, and then the advancement flaps are done in order to release things.